Oh, no, I didn't. You guys, I think you can start the quiz. I think it may not open until 1, but go ahead and try and see if you can. Yeah, it might not be open yet.
Yeah, it's not open till 1.
Okay. Okay, I should get myself together here. Let's see. Make sure I'm recording. I am recording. I guess we don't have to record yet. Someone remind me to press record though. If I pause it, remind me I'm recording. Okay. Okay, so we're going to talk about the respiratory system. Here's the objectives and I always probably tell you guys this, but I can't, everything kind of disappears when I go into share screen. So just speak up. If someone has a question, just unmute and just start talking, because the chat, I can't follow the chat very good. So identify the function and anatomy of the respiratory system, discuss allergic rhinitis. We'll also talk about, included with the allergic rhinitis is also the viral rhinitis. Sorry, my phone's ringing. Asthma and COPD, and then the anatomy and function, a little bit etiology, pathophysiology, and complications. And then we're going to talk about the drugs that are used to treat those conditions. And we want to really highlight the oral. In all of these medications, the biggest adverse effects that we'll pay attention to, because you guys know by now there's like a bajillion adverse effects. So we want to think about the ones that affect during patient care, and then the ones that affect the patient's oral environment. All right, so here's a picture of the lungs from the textbook. So we'll go through the anatomy just briefly. So air is taken in through we're supposed to breathe through our nose. We're not supposed to breathe through our mouth, although that happens, but air is taken in through the nasal cavity, comes on down here. I want to use my cursor where you guys can see, comes down through the trachea, down into the lungs, and then it kind of starts to branch off into the, oh my word, bronchioles. And then after it gets through those branches, it branches even further into the alveoli. So those are these little tiny thin cells down at the bottom that fill up with the air. And so there's all these little branches. I wish this was a little bit more see-through so you could see, but after they break off from the bronchioli, then they divide even further into the alveoli. And so from here, this is where the exchange of oxygen, this is where the exchange of oxygen and carbon monoxide come in and out from the alveoli into the circulation, all the little blood vessels and capillaries that surround the alveoli. That's where the actual oxygen and carbon monoxide or dioxide, sorry, transition happens, is in these little air sacs down around in here. So to connect this back to the autonomic nervous system, type into, or just say it out loud. You can either type it into the chat, but I probably won't be able to catch it very good. But does anybody remember what happens when the sympathetic or the fight and flight gets kicked on with our lungs and our bronchioles? What happens then?
It dilates.
Mm-hmm. Yeah, so we dilate because we need oxygen, right? We're freaked out. We need to run away and get, or we're exercising or whatever got us, kind of heightened. And so that's when we need oxygen. So they dilate to let more oxygen in. When we're at rest and we're really relaxed, everything kind of closes down because we don't need as much oxygen. We're just kind of hanging out and we're relaxed. So the sympathetic nervous system dilates the smooth muscle of the lungs. Okay, so, and I just kind of said this first part here. So air enters through these passageways, and then so they call it the tracheobronchial, tracheobronchial tree, and then it ends in those little alveoli. So does anybody remember from the reading roughly how many alveoli are at the tail end? Probably someone has maybe written it in the chat. So roughly we have 23 divisions, and that's how many alveoli are at the tail, at the kind of the tail end of the bronchi. So the airway is surrounded by smooth muscle, and we know that I'm supposed to ask you guys this. So do you remember which receptors are going to be triggered in the sympathetic nervous system that affect the smooth muscle of the lungs? Which receptor?
B2.
Beta 2. Good. I know, try and connect it all back. So the stuff that we've read before kind of reminds us of what, and puts it together and reminds us what we're learning this week. So yeah, beta 2. So this statement from the textbook, I have to say, I didn't really understand. I was trying to read this over and over again, and it's backwards in my mind. So I don't know if this, but it says when the muscles are stimulated, they contract, narrowing the lumen, which is true. If it's, like if you're having an asthma attack, that's what's happening is it's contracting, you're getting inflammation and things are closing down, and then the lumen is narrowing. But then it says diameter is opening. So does anybody else feel like that's the exact opposite statement? Because if the diameter, the lumen is like the inside part, and that should be opening. So when you're
Leslie, I had a good way to think about this. So if pretend you're looking at, this is such a weird example, but a noodle that has a center. If you know how if you press down on it, you don't close it all the way, but you just slightly press on it, it becomes more oval and less circle. I think that's what it means. That's what I took it as, at least.
Oh, that's interesting, because I was like, the lumen is narrowing, but the diameter is opening. So I almost took it out, but it's in the textbook. So I just kept saying, maybe the students will have some insight. Did anybody else find this phrase weird? That just might be it, McKenna. I'm just not 100% positive. But
yeah, I have no idea.
Everyone's like, no, I don't know. Well, maybe I'll get some input from Holly, who taught this last year. And so maybe she has some input on that. So I don't know. We'll move on from that phrase, but I wondered if that confused anybody. Okay, so just as a reminder for the receptors and what they do when they get stimulated. So the alpha-1 receptors are the smooth muscle on the lungs and the vasculature. So the smooth muscle, it's gonna contract. So if an alpha-1 gets stimulated, it's gonna cause, so that's what we have to be worried about. If somebody has asthma and is taking a medication that stimulates alpha-1, you have to be aware of that, how it's not necessarily selective specifically for what it can affect other parts of the body. So we have to be aware of that. And then the vasculature, vasoconstriction of the blood vessels. Beta 2 is the predominant one that we're going to be thinking about when we think of medications for asthma or opening up the lungs. And you guys have already talked about that. Even last week, I know someone mentioned it to Dr. Beggert. So now the one that we're introducing that's new is H1, and that's histamine 1. And we'll talk about that a little bit more. And then leukotrienes, which also cause bronchoconstriction when they're stimulated. So H1, histamine 1, they cause bronchoconstriction and bronchial mucus secretion and congestion. So these are ones that we have to be concerned with if they get stimulated for somebody who has some kind of a lung condition. So they're kind of like two added ones here. So the lung diseases that we're going to review are rhinitis, asthma, and COPD. And then we'll start with rhinitis, which is basically inflammation of the nasal mucosa. Allergic rhinitis is incredibly common. Lots and lots of, half of America practically has some kind of seasonal allergy or maybe some more significant allergy, but allergic rhinitis is very common. And then allergies do appear to be on the rise in general, and typically men seem to suffer more from allergies than women.
Leslie,
Yeah.
I have a question, and I think that it's off topic, but it bothers me every time I have this thought, and I forget to ask like every time. So I think I need to just ask it. So whenever you're asking about a receptor that has an effect on blood pressure, I always want to say baroreceptors, and it's never the answer you're looking for. So is there any way you can explain that? Like, do you know why I was taught that it was baroreceptors that like have an effect on blood pressure and not, I don't even know the one that you're usually looking for, because I just have baroreceptors in my brain for that one.
I have no idea. Is that what class was that in a science course, like a prerequisite course?
Yeah, that was just anatomy in general. And I think it's like, I think baroreceptors are just like all over, and maybe you're asking for like a more like specific area receptor or something.
Yeah, because the systems are so much more complex, really. I mean, I know that what we're even just covering seems incredibly complex, but when I will go and dig a little bit deeper to kind of just help like my personal understanding of the topic, I'll watch like different videos or read different things, they'll bring in terms that aren't in our textbook. And then I'm like, oh shoot, I got to try and keep that out of my head because I don't want to test on something that is, you know what I'm saying? So there are so many systems and probably receptors and things like that are different pieces of the puzzle that we're just, and it's like getting in the weeds. It's like what doctors need to know, but it's not what we need to know. So I have no idea specifically about that one, but I'm sorry that you keep referring back to it, probably because you learned it in some other science class, but yeah.
Okay, I just wanted to make sure. So I'm just going to completely try to erase that from my brain.
Rub it out.
Okay, thank you.
Okay, so the common allergens include, like what you see here, pollen, dust, ragweed, and then viral rhinitis, or what is referred to as the common cold, presents with many of the same symptoms as allergic rhinitis, but the cause is different, obviously. So viral rhinitis, the symptoms come from being infected. We are like experts on this for, sort of, although I know we're dealing with more than the common cold, but they come from aerosols or droplets, and the common cold comes from over one of more than 200 different viruses. I mean, that could even be a very small number. That was just what I saw from the textbook and from one other source. The virus is rhinovirus is the most common, but other very common ones is the coronavirus, adenovirus, and respiratory syncytial virus. I should have practiced that before. So far, there's no prevention, obviously, for the common cold. You can't make a vaccine for it because there's just too many strains. You just can't keep up with it. So our best defense is what we've been harping on for over a year now. Hand washing, keep up your immune system, stay healthy, and hopefully the duration of the common cold will not, be more, but oftentimes we can have a cold for over a week, 10 days to 2 weeks. So with allergic rhinitis, your body is basically overreacting. So that's viral rhinitis is from a virus, but allergic rhinitis, your body is basically overreacting to an allergen. So we have these cells in our body called mast cells, and those mast cells contain histamine. And when you introduce a little speck of pollen, or whatever that allergen is, it latches onto this little allergy antibody body right here, this little thing that's shaped like a Y, the pollen latches on and it sends a signal to the mast cell to release histamine. And then when you release histamine, then that's when you get all these side effects of itchy, watery eyes, nasal congestion, all those symptoms. So I'm going to, if I play this, hopefully you guys will hear the audio. Tell me right away if you can't, and I will just skip the video. Because I know sometimes this doesn't work.
Leslie, I'm pretty sure that's a PDF because I couldn't click on it. I just had to kind of copy it and then paste it into my browser.
Okay. Although mine should not be.
I just went on YouTube and I looked up allergic rhinitis Khan Academy.
Okay. Hold on. I think it wasn't, there we go. Mine's not a PDF. I have a different one then. So it should have been, but I think it wasn't allowing me to because I was like in that blown up screen share mode. So now it's just contacting the server. It's just taking a really long time. I might just skip it. Oh wait, now it's working. I think the video is kind of lengthy, and so I didn't want to use up too much time with it, and it's already taking too much time to load. So, all right, now it's doing it. I'm like just about to give up, and then it changes, and I think, oh, okay, I guess maybe I just wanted to show you guys at least the first few, kind of the middle of it, because it just does a nice explanation of what mast cells do.
And that's the only way I made it through A&P was with Khan Academy.
I'd never seen this before. I had never heard of this. It was just
insanely smart.
It was a really good video. I really liked it. It's just
Leslie, while you're pulling it up, mast cells basically just release histamines, right?
Mm-hmm. They're full of little histamines, and when they get triggered, they release the histamine. So they get triggered by something binding to the antibody site on the outside.
Mm-hmm. And it would be the allergens binding.
Mm-hmm. Right? Yep, when the allergens bind. Oh my word, this is taking far too long. So it's just.
And itis just means inflammation.
Can you guys hear
this?
This
is an inflammation of the nose. And allergic just means that it's caused by allergies. So let's go ahead and draw our nose here. Now this is the outside of the nose, but the inside of the nose is covered with a smooth lining. And that smooth lining is called mucosa. Now mucosa lines everything inside your nose, but it's not just totally smooth in there. There are these bones that stick out that are called concha. And these concha kind of stick out from the side of the wall of the nose, and they can take up almost all the space in there. But in order to figure out what's happening a little bit better, we have to zoom in. And we have to zoom in all the way to the level of the cells. And so here I'm drawing some of the cells of the nasal mucosa. These are big globular pink cells. But there's a couple cells in here that are different. These are cells of your immune system. The ones that we're worried about, the immune cells in the nose that deal with allergic rhinitis, are called mast cells and basophils. So let's say this particular nose and this particular set of cells has allergic rhinitis. What exactly is happening? Well, in allergic rhinitis, like with any allergy, your body has an overreaction to some sort of stimulus in the environment. And that stimulus is called an allergen. And let's take a little side note here and talk about the allergens that are common to people who suffer from allergic rhinitis. Isn't a fever. Pollen also tends to be seasonal. But basically anything that can get into the air that you can inhale can act as an allergen to somebody who suffers from allergic rhinitis. So let's say this nose and this group of cells are out there in the environment doing their thing, breathing, and suck up something that's going to act as an allergen. So that allergen goes into the nose. We'll erase a little bit here. And that allergen is going to come into contact with this mast cell over here. Being a mast cell or a basophil, on its surface it has a particular protein that's shaped a little bit like a Y, and that protein is called an immune globulin, which is shortened to Ig. And this particular type of immune globulin is called IgE. There are other types of immune globulins, IgG and IgM, but for allergic rhinitis, we're concerned with IgE. This little grain of pollen, or whatever the allergen is, let's assume it's pollen here, is going to get bound by this IgE molecule. And that IgE molecule, again, just a protein sitting on the surface of this basophil, is going to alert that cell to its presence. Now, in a normal person, the reaction that that cell has should be pretty minimal. I mean, it's just a grain of pollen. It's not like it's an infectious agent that's going to go in and give your body all sorts of trouble. But in a person that suffers from allergic rhinitis, this cell overreacts, and it overreacts big time. And when it sees that pollen grain, it starts letting out little molecules into its environment that tell all the cells around it to get excited as well. So this whole group of nasal mucosa gets overreacted. The most common type of molecule that's used for signaling here is called a histamine. So now that these immune cells are overreacting and causing all the cells around them to overreact to this allergen, we can predict what is going to happen inside the nose on a larger scale. Well, I'm going to draw some of this inflammation on these ridges in the nose, the turbinates, but it's happening kind of everywhere. And in addition to becoming swollen, this mucosa is going to start to overproduce mucus. And that mucus is going to drip down along the turbinates. It's going to drip down the sides of the nose here. It's going to form big drips that hang down inside your nose. And of course, your nose is not an isolated thing. And as this mucus pools in your nasal cavity, it's going to head down this way, and that is towards your throat. So you can cough this stuff up as well. But your throat isn't the only thing that's attached to your nose. In fact, there's a tube that lives right about here that opens up just underneath this first ridge, right about there. And as the mucosa swells up, it can swell that tube shut. And that tube is called the nasolacrimal duct. And it connects your nose to your eye. And its job is to drain the tears out of your eye and into your nose where you don't even notice them. Now, when that duct gets swollen shut, the tears don't have anywhere to go. And that's going to lead to watery eyes. There's another tube that can be affected at the back of your throat, and that tube is connected to your ear. And it's called the eustachian tube. And similarly, if the swelling gets bad enough, it can block off the eustachian tube and cause fluid to back up in this. And that's going to lead to symptoms with your ear, particularly stuffiness and decreased ability.
Okay, I'm going to stop it there. You guys can always go back and watch the thing from beginning to end, but I just like the way he explains stuff. It's so like clear to me. I hope it is to you guys. Okay, let me share this again. Of course, it starts from the beginning. Okay, so like he said in the video, the signs of rhinitis are nasal congestion, runny nose, itching, watery eyes, sneezing, and mucus production. And how we treat allergic rhinitis is you want to try and avoid the allergens if you can, although that's kind of hard to do for a lot of people. And then of course we have medications to help with the symptoms anyways. So, oh my gosh, that's not what I had. Okay, anyways, I had changed this. Sometimes the PowerPoints don't update the way I'll have worked on it and changed something around, and then it doesn't update, and I just must have done something wrong. So what I wanted you to do was to just think about, it says think, pair, share, but I had put just type into the chat box or just shout it out. What do you guys use to treat a cold or allergies? But what more specifically do you not use? So what would not work at all in prescription wise? I'm not thinking over the counter, I'm thinking prescription wise. What would not work at all on allergic rhinitis or viral rhinitis? And this little link goes to more about what I'm referring to, so that we won't click on this now. This is something you guys can look at. But does anybody have an idea of what do some people want to always go to when they're sick, but it doesn't always necessarily be the medication that somebody needs? Anybody want to shout it out?
Tylenol.
Tylenol. I'm thinking prescription specifically.
Like Tylenol codeine.
Somebody wrote it in the chat here, antibiotics. So sometimes people are like, every time they're sick, they want to do antibiotics. I feel like we have been kind of, we've heard a lot about it in the, like over the last few years in the news. So I feel like it's a little bit maybe better here, and maybe we're a little bit more educated on that. But some places where antibiotics can be over the counter, or that you don't need a prescription, people use them for all sorts of things that they're not going to work for. Like an antibiotic is not going to work on a virus, right? So that's the main point is you need to use, you either have to write it out or you treat the symptoms, but you can't kill it with an antibiotic, because that's for bacteria, not for viruses. Okay. So the families of medications that, I'm so sorry, you guys. I have to stop sharing really fast for just a second. Okay. I found the one that I couldn't find before, that I was like, where is my typing that I had done? And I found it. That's why I had to stop. Sorry. Okay. See, it's green. So I had said, what do you not take to treat a viral cold? And it was antibiotics. Okay, so there's basically 3 families of medications to treat a cold or allergies, and they are mast cell blockers, antihistamines or histamine blockers, decongestants, and intranasal steroids. And they do these things. They slow down the mast cell blockers or the histamine blockers. They slow down the reaction. Decongestants kind of thin things out and open things up. And then intranasal steroids calm down the inflammation. Okay, so the first one is the mast cell stabilizer or inhibitors, and we use those to prevent and treat symptoms, which is pretty much what all of these are for. The mechanism of action is they prevent the mast cell from, they sort of block the mast cell just out the gate. So they don't block the histamine, they're like blocking the mast cell itself from getting triggered at all. And then, but this takes a while because they're blocking this immune cell, this big immune cell that has more little parts to it. It takes longer for the onset for it actually to work. So this takes the time for relief from symptoms is slow, 1 to 2 weeks. So for allergies, like if you have seasonal allergies and you have them for like a couple months, or 6 weeks or something like that, then this is probably fine. But if you're dealing with something that's just happening like over a weekend or something, you obviously wouldn't choose this medication. Adverse effects are nasal burning and stinging, and then the medication is nasal crom. The second one is the antihistamine or the histamine blockers, and uses prevent or treat. Mechanism of action, they block histamine from binding to the H1 receptors, where in the nose, so all those little nose cells everywhere, when the histamine goes out and like hooks on and tells all the other cells to freak out, like what he said in the video, it blocks it at that point, so they don't actually hook onto the cells and cause the reaction. So there's two different generations. There's the first generation and the second, and we'll talk about that a little bit more. The time to relief is much faster. It happens far more quickly, like within hours. And then the biggest adverse effect is dry mouth or xerostomia. And then there is the anticholinergic effect, or what we call SLUD, which is decreased salivation, decreased lacrimation, which is dry eyes, decreased urination, and decreased defecation. Everything dries up, basically. It's kind of drying is pretty much everything, anything that's anticholinergic. And then it also causes some mild sedation or drowsiness. And that varies depending on the dosage and probably the person as well. So the first generation of the histamine blocker. Oh, yeah, yeah.
Is the antihistamine drug name? Oh, we're right here. Never mind.
You're up to speed. Okay. I think someone was cutting out a little bit. So if I'm missing your question, just keep trying. So the first generation of the histamine blockers is Benadryl is the brand name. Diphenhydramine. I was saying this earlier. Today, my brain isn't saying words very well. I don't know if anybody noticed, but I'm not saying words very good today. Some days I'm on top of it better than others. The anticholinergic activity of Benadryl is very high, and the sedation is very high. Benadryl is also used for other things, and one of them sometimes is to make you sleepy and sleep. You know, Tylenol PM basically has diphenhydramine in it. So it has a lot of side effects that aren't particularly desirable, and then some that they use, you know, some of the side effects they use to actually accomplish something. The second generation, though, of histamine blockers causes far less sedation and less of the anticholinergic activity, or the SLUD. So these are actually far more popular for use with seasonal allergies or allergic rhinitis. So Claritin, Zyrtec, Allegra, these ones are used more commonly than Benadryl for seasonal allergies. So the next one is the decongestants, and these they constrict blood vessels and reduce inflammation and the mucus production in the nose. And then their side effect as well is xerostomia. There can be stinging or burning or nasal dryness. And then they can also cause a systemic effect of increased blood pressure or heart rate. And then one of the biggest problems with these decongestants is that they can work for a few days, and then all of a sudden you can have a very strong rebound where they kind of stop working, and then you plug up and they don't seem to work very well anymore. So Sudafed, Sudafed is over the counter in some places, but it's one of the decongestants. But it's not over the counter in Oregon. It's a prescription in Oregon, or you have to, I know some places you have to ask the pharmacist for it, and some places you have to get a prescription. So it just depends on the state. But Sudafed is a Schedule 3 drug in Oregon, so it is a prescription. Sudafed PE, which is, I'm not sure if it's the dosage that's different there. That is over the counter, but I still think you have to ask the pharmacist. It's in the pharmacy department. You have to ask them for it. And then Afrin is one of the, and this one too, these ones that you spray up your nose, those are the ones that tend to have the rebound. The intranasal sprays, they tend to have some of the stronger rebound. So you just have to be careful when you use them, you know, how long you're using it for and how much. And then if you've had that happen in the past, I know some people who've used them and they don't ever get the rebound, and then other people have gotten it. So I don't know if it's just a personal, you know, it's an adverse effect that maybe not everybody gets. And I don't know if any of you wondered why it's a Sudafed or pseudoephedrine is Schedule 3, but it's and you probably have heard this before, it's a precursor to methamphetamine production. When people are making meth, they can use pseudoephedrine. So the intranasal corticosteroids, that's the next category. These all basically reduce inflammation inside the nose. They inhibit the mast cells and the mediators like the leukotrienes. And so these take a few days to actually start working really well, so they don't start working immediately. And then adverse effects of these is the stinging and the burning and the drying of the nasal mucosa. Flonase is over the counter. It used to be prescription, but now it's over the counter. And then Veramist and Nasonex.
Leslie, do you want us to know the dose?
I don't think so. I was just noticing that the dose was sort of highlighted. I'll look ahead, and if there is any dosage questions, I'll be sure to let you guys know. Let me make a note. Okay. So, and then here's just a little chart for you to fill in to kind of test yourself a little bit. So does anybody remember which one loratadine is from a few slides ago?
It's a second antihistamine.
It's a second generation antihistamine. Do you remember the brand name?
Oh, Claritin.
Right, Claritin. And then how does it work?
It blocks histamine from binding to the H1 receptor.
Yep, good. Just like it says here for the Zyrtec, it blocks the histamine from binding to the H1 receptors. It is the second generation antihistamine, so there's less, just like this one says here, it has the less sedation and less anticholinergic. So you guys can just kind of write some of these down to kind of help you remember. Next one is, okay, well, we'll just, I don't want to run. I want to give you guys a break. Okay, let's do this. Oh, hold on. I have a question really quick. Yep. Thank you, Trey. That's pretty much what I would have said. So, okay, so let's just go over this little case real quick, and then I'll give you guys a break because we are about halfway. So a 28-year-old female is returning from a routine dental cleaning. A few days ago, she came down with a cold. Her symptoms include watery and itchy eyes, sneezing, and nasal congestion. She denies coughing, aching, fever, or chills. She's been taking Benadryl every 4 to 6 hours, and as instructed on the box. It's helped relieve her itchy, watery eyes and sneezing, but she feels tired, kind of zoned out. She's still congested and has not been getting quality sleep. She breathes through her mouth and believes that's why she has dry mouth. So can you explain why the Benadryl helped her itchy, watery eyes and sneezing, but hasn't really helped her nasal congestion? What do you guys think about that?
It would block the histamine, but wouldn't deal with the inflammation.
anything else?
It's probably caused by a virus and not allergies.
Mm-hmm. Good. Yeah, that's I think that's kind of because you can get that inflammation with your allergies, right? But if it's a viral thing, it's not really going to have an effect on it. It's not going to be, because it's the histamines that are causing your inflammation if it's an allergic thing. But if it's the virus that's causing the inflammation, then you're not going to get as much of a response or any with Benadryl. So good. So which drug might be better for relieving her nasal congestion, since Benadryl is not really giving her any relief there?
Be a decongestant.
Mm-hmm. Yeah, a decongestant or an intranasal corticosteroid, one of those two things. Both of those would deal with the inflammation and the congestion. The corticosteroid would help relieve the specific inflammation, but the decongestant would also help at least dry her up and let her breathe. So yeah, either one of those. Okay, what may be causing her dry mouth?
The Benadryl has high anticholinergic reaction, right?
Mm-hmm, exactly. Yep. So the anticholinergic activity of the Benadryl, that'll really give the dry mouth. And then what drug might be better for relieving her itchy, watery eyes and sneezing that would be less drying?
Maybe like Claritin or
Mm-hmm.
something.
So a second generation, if she just had itchy, watery eyes and that sort of thing, and that was something that she just needed a different antihistamine, if we weren't dealing with the viral, then yeah, a second generation would give her less dry mouth. Good. Okay. So then let's stop there. We're at a good stopping point because then we're going to move on to asthma. It's 2:00, so let's give, I have 2:01, so let's come back at 2:10.
Leslie, can I talk to you real quick?
Yeah.
Okay. I totally missed the first half of this lecture because I thought it was at 2 for whatever reason. I have no idea why I did that. So I know I missed the quiz. Would there be any way to do the quiz in between this class and perio, and then you obviously would take 25% off because it's late? Or no?
You can, can you see if you can log into the quiz now?
Yeah, I can take a look. I literally have I woke up this morning and was like, oh, my class is at 2, and I have no idea why.
Probably because of last week.
That could be it, because I literally just got on and I was like, am I missing something? But now I just remembered. Okay, it is attempt quiz now.
If you can, yeah, I think it's still open, so you can go ahead and take it, and it's timed 10 minutes.
Okay, perfect. I'll do it right now. Thank you.
Hey, Leslie, can I ask you a quick question?
Yeah.
I wanted a quick reminder. So, are we memorizing the mechanism of action also on drugs, or just like?
I do think that it's gonna be I think it's gonna be asked on some questions in the exams. The exams are older for this class, so they've been written, and I can go in and alter them, which I'll probably do a little bit, but there's the bulk of them are already there. So I am assuming that there's questions that deal with the mechanism of action, because if it's highlighted on a PowerPoint, I'm assuming it's fair game for test material. So I do think that's part of it. I think like mechanism of action, adverse effects that are specified in the PowerPoint, not just any old effect, but like something that's specified in the PowerPoint, and then in general what the drug is used for. So
I'm
like
looking on the top 20. Yeah, I'm just trying to make sure that I do everything. I'm like trying to do like one a day because there's so many. So I'm like, okay, I'll memorize one a day. And then, like, I don't know how else to do it, so the information kind of stays.
Well, and are you thinking like, so this is what I think I'm going to do, because I think this is that I haven't cross-checked this. So I'm going to look at your top 20 drug list, and I'm going to cross-reference it with all the drugs that are listed in the PowerPoints for the semester, and make sure that they're all there. Because basically, if they're all there, you don't have to think about them as two separate things. You can just deal with the respiratory drugs when you're covering respiratory. You deal with the cardiovascular drugs when you're doing, you know what I mean? Because I don't think the top 20 shouldn't be in addition to what's listed in the PowerPoints under the section that we're working on.
Oh, I see what you're saying.
Do you know what I mean? Like, and then what they've done in the past, and I think it's just gotten muddled through the years, but I think when Amy first started teaching this course originally, because she taught it, I think in the beginning when the program started, she taught it for like the first 9 years or something. I think what she did, which I'm gonna try and go back to this, is make the top 20 highlighted in the PowerPoint. So it was like, those were the drugs. So they're in the PowerPoint. They're also sort of isolated in the top 20, and they're highlighted in red. So you're kind of seeing them and they stand out to you. And those are the drugs that are, but.
So are you not gonna ask us on a test about a drug that we haven't covered in a PowerPoint yet?
No, I'm not going to ask you about a drug that you will have had it in the PowerPoint. That's why I want to cross-reference the top 20.
Even if it's on the top 20, if we haven't discussed it in a PowerPoint yet, you're not going to ask us about it.
Yeah, and I think that's what happened with those Zoloft. That's why I took the Zoloft one out, because even though it's in, we'll talk about it later, I thought, I'm just going to wipe that one out, because we really didn't talk about, even though it's a top 20 drug.
That helps a lot, because I was about to literally memorize all of them before the test.
Yeah.
I know that we have to know them, but like, if I can save some room.
Yeah, it's like now just focus on the respiratory, and then, and then when you have your exam, I'll say, I'll pull out the drugs that I want you guys to focus on for the exam. Like, it doesn't mean it's exclusive, but I'll say, these are the drugs that you really need to know for the exam. And they're, it's not like I'm just going to give you just the ones that are on the exam, but I'm going to say these are the ones that so just so it dials you in a little bit better.
Okay, no, that's super helpful. Thank you. Some of the mechanisms are like a paragraph long too.
Yeah, and it needs to be like a simple understanding, like blocks histamine, or is like a like it's a adrenergic, agonist, or antagonist, something like that, like an alpha blocker. It's something like that you can say in a phrase, not like this big like blah 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 blah, because that's just too much.
Okay. So like we haven't talked about like antidepressants yet.
Yeah, so you don't have to worry about memorizing those yet.
Okay. Okay. Cool. Thank you.
Okay, we're 210. So let me get back to what I was, find the right PowerPoint, because I have one that's right and one that's old. Too many versions of stuff. And it always starts from the beginning. I do not know why that is. Okay, so asthma. So now we're going to talk about asthma. So asthma is a chronic lung disease that's characterized by inflammation in the airways and then bronchoconstriction. And this also is fairly common, although 15 million, there's like over 300 million Americans. So 15 million is not a huge part of the population, but it's common enough. 5% of children younger than 18 reporting having an asthma attack. Some people do, you hear like grow out of it. People grow out of their asthma. So that can happen as well. Let me advance the slide. So a little bit of the pathophysiology. So what causes the airway to inflame? There's 3 mediators: the T lymphocytes and the eosinophils, the leukotrienes, and the mast cells. So those mediators listed in the bullet points, they narrow the airway by causing edema or swelling and inflammation. So the T lymphocytes, the eosinophils, the leukotrienes, and the mast cells. There's also extra production of mucus that also causes some kind of like a retention. Again, kind of narrows the airway, makes the air hard to get through because you have the swelling and then you have the thick lining of the mucus, and it just all narrows the airway. And then the mucus also does what they call like plugging, and just kind of binds stuff up and makes it so that air just isn't moving well through the lungs. Inflammation happens rapidly, that happens pretty fast, but the mucus production can be kind of slow to come on.
So all of those that you just mentioned, Leslie, I'm just making sure I understand, versus airway inflammation occurs, all those cells, they narrow the airway.
Yep, so the T lymphocytes and the eosinophils, they're white blood cells involved in the inflammatory response. Because you remember, like, our immune system, it's the same, you can kind of think about it like periodontal disease. Inflammation goes to these areas to initially like try and help, but usually what happens is it makes it worse because it's like an overreaction. So we have like, some immune responses that just kind of get out of hand or overreact and start causing damage. So yeah, they all cause basically an inflammation or an excessive mucus production, which ultimately just narrows the airway. Okay, so was I on the right? Yes, okay. So then the other thing, so first we have the narrowing of the airway, we have airway inflammation, and we have the mucus production, and then we have bronchospasms, and then we also have lung hyperinflammation or air trapping. Air gets trapped down in the air alveoli and can't get back out again, and then you can't get fresh oxygen in to like replace it. So that's what the air trapping is. And then the airway walls start to remodel or change shape a little bit in chronic asthma. So remodeling is like changing shape to something that's not as conducive to breathing. So with the bronchospasms, it's mediated by the beta-2 receptors. So does that mean that they're being blocked or activated? So if you're having constriction, are the beta-2 being blocked or activated?
They would be blocked, right?
Yeah, they're being blocked, right? Okay, so the triggers vary from person to person. The textbook even talked about, I don't know if you guys read this, but thunderstorms, because it says here like change in weather, but thunderstorms can trigger an asthma attack. And I don't know if that is something physically in the air that's causing irritation. I wanted to like look it up. Does anybody know about that? I thought that was so interesting. If nobody has heard that or knows the details, I'm going to look it up and find out why. I know that when I lived in Arizona, you could smell the air changed. Like you could smell it in the air. So I don't know if that has something to do with it, but I thought that was really interesting. Oh, air pressure. Yes, that makes sense. And I'll have to like look more into that and get but that does make sense. The barometer change in the air pressure. Okay. So different things trigger exercise, and also just a viral infection can also trigger it. So all different things for different people. So we have a couple different categories of asthma. We have mild intermittent, and that happens 2 times a week or less. And it could happen like it could wake them up in the middle of the night. So if you're woken up 2 times or less, or if your symptoms happen during the day 2 times or less in a week, then that's mild intermittent. Mild persistent occurs more than twice a week. Moderate persistent occurs almost daily. And severe persistent or status asthmaticus is a type that you're pretty much hospitalized because you're having one asthma attack after the other without any kind of relief in between. So that is something completely different and serious, and they'd be hospitalized. Signs of asthma: wheezing, coughing, dyspnea is labored breathing or difficulty breathing, and then tightness in the chest. And you can see throughout there's these little illustrations of the narrowing of the airway, mucus thickening, everything just kind of closing down in so that it's like breathing through a little straw instead of like be able to get a nice big breath. This is an X-ray image of a normal lung and then an asthmatic lung. You can just see how it's radiopaque. More you can see like, especially down in here and over down in the bottom parts of the lungs, there's like more, you can almost see the branching. So they become more radiopaque. They're just thicker. So you can see them more on the X-ray. I'm not going to bother with this because it just took too long, but I think what this was an asthma video. So go ahead and watch that. It shows kind of gives an animation of what's happening with the bronchioles closing. So go ahead and type into the chat, if you were a medication treating asthma, how would you work to eliminate an asthma attack? I feel like we've kind of beat this over the head a billion times, but what kind of medication would you be, or what would you want to be doing if you were an asthma medication? So you can type it into the chat or you can say it.
Bronchodilation.
Yes, you would want to open things up, right? You'd want to reduce inflammation and you'd want to open things up. So one of the things we know we can use is like a beta-2, right? Beta-2 agonist to encourage that, to open up. And then something that's anti-inflammatory or corticosteroid too, to get rid of the inflammation. So the current treatments for asthma are to eliminate the triggers. So if it's pollen or if it's, whatever the trigger is, if it's dust or, you try to do your best to eliminate those triggers. And then there are some medications that we'll discuss. There are relievers. that work short term, and then there are drugs that are kind of controllers and preventers. So the ones that are relievers, sometimes we call them like the rescue inhalers and things like that. So before we go into the medications though, we're going to go over COPD because pretty much the medications are very closely aligned. What you use for asthma, you use for COPD often. There's a little bit of difference, but so we're just going to do the pathophysiology of COPD before we go over the medications, because otherwise it's kind of repetitive. So chronic obstructive pulmonary disease is COPD, and it progresses slowly. It's a slowly progressing disease, and once somebody's kind of expresses COPD or starts to develop it, and there is no cure and there's no going back. It's like a permanent thing, but they can slow the process and treat the symptoms. So COPD is the 4th leading cause of death in the United States. And basically what COPD is it's a combination of emphysema and chronic bronchitis. So when you have emphysema and chronic bronchitis together, you have COPD. So the most significant cause of COPD is cigarette smoking. There is information that says that pipe smoking and cigar smoking can also be linked to emphysema and COPD, but predominantly traditional cigarette smoking is the highest risk factor, and it accounts for 80 to 90% of the deaths from COPD is from smokers. But this is kind of interesting. Despite the risk, only 1 in 5 smokers develop COPD. So it's obviously has something to do with probably, again, there's, they say your, what's the common thing, your genes load the gun, but environment pulls the trigger. So some people might be genetically at a disposition, like genetically at a disadvantage, or they might be more likely to get COPD. But if they never smoked and they live a healthy lifestyle, it would never express itself. But if you have that genetic disposition and then you smoke, so sometimes that can play a role in that or it also could be, do you smoke 5 cigarettes a day or do you smoke 2 packs a day? How much do you smoke? Smoking is definitely going out of style though. So I know this is not as common as it used to be, like when I was growing up. But the breakdown of the 2 conditions, chronic bronchitis is physical changes in the bronchial walls, and the airway is being obstructed. So there's thickening of the bronchial walls, there's more mucus being produced due to the increased size of the mucus glands actually get larger, and so they produce more mucus. And then there's a smaller airway. We see the narrowing of the airway, increased sputum, or the mucus production, this mucus plugging again, things get plugged up, and then airway collapse. So things get kind of overinflated sometimes and then can collapse down, and then they won't inflate again. So you can't get that oxygen exchange. With emphysema, the smoke from the cigarettes injures the alveoli epithelium. And when this happens, neutrophils are attracted to the site of injury because they're an immune mediator as well. But the neutrophils release an enzyme that causes more damage. So it's kind of like a vicious cycle. Like the cigarette causes damage, and then your body goes to fix it or tries to help, but then it ends up causing more because it's overreacting to its inflammatory response, because inflammation is supposed to protect, but it's supposed to be temporary, just to get rid of something temporarily and then go away. But if you have this chronic thing that you keep having to mess with, or they keep smoking and causing more and more damage, then these inflammatory mediators just keep coming, and so you never get out of that cycle. And that's the inflammatory mediators, the neutrophils, that continue to destroy the walls of the alveoli. So the air spaces enlarge, you lose elasticity, and then you get the airway collapses upon when the patient breathes out. So this little image here, kind of a lot of this stuff, the A1AT, I wanted to just mention, you guys can just ignore that. That's alpha 1, but it's antitrypsin and antitrypsin. So you don't have to worry about that. So I don't want that to confuse you like A1, like the alpha 1 that we've been talking about in previous chapters. This functional A1AT has to do with a different receptor or different, and it's actually a protein that's produced in the body, and it's a protective protein. And so there is some studies that show that non-smokers who have COPD might have a deficiency of A1 antitrypsin. So scrub that out of your mind. You don't have to know that for exams. That just happens to be in this image. But what you do want to know is that the nicotine stimulates the neutrophil response, which causes tissue damage. So that's the part that you guys need to pay attention to. You can ignore the kind of internal stuff there. So signs of COPD, signs of chronic bronchitis is chronic cough, bringing up some sputum. Patients or individuals are usually more sedentary, or they don't move around a lot, tend to be overweight. They can have a bluishness. They used to call it blue bloater. I don't know if they call that anymore, but that's where this picture comes from. But because there could be like a blue look to their nail beds, and maybe even to like their mouth if they're just not quite getting enough oxygen. Edematous, they can have swelling, and then a breathlessness, like they just can't get enough air. With emphysema, some signs are labored breathing or difficulty breathing with the dyspnea. Enlarged chest, that's actually trapped oxygen. So that's that air trapping. So if someone gets a barrel chest, that's actually from like air trapped. And then weight loss, or as the disease progresses, cyanosis, usually not seen. That's probably terminal, like in much later stages. So treatment for COPD, there's no cure. We just treat the symptoms, avoid the irritants. Smoking cessation obviously is a big one, and then pharmacological management. And this is just a slide that shows the expense and the money saving. If you do quit smoking, if someone's smoking in the first year, they'll save thousands, and within 5 years, if they smoke like a pack a day, it's calculated on a pack a day, it's like practically $14,000 savings in a 5-year periods. And I don't even know if that's based on today's prices. A pack of cigarettes is super expensive. It's more than $5, I think, but I think it's less than 10, but it's a lot of money. Okay, so asthma and so now we'll talk about the medication or the drug therapies for both. Okay. Okay, so both conditions we see beta 2 agonists and the corticosteroids being used for asthma. We see the leukotriene receptor antagonists for asthma, and then the anticholinergic medications for COPD. So with the beta 2 agonists, for both of them, we want that bronchodilation, corticosteroids for the anti-inflammatory. This is also for bronchodilation, and then this as well, the anticholinergic, or to block the constriction. So for our beta 2, we have short-term and we have long-term. The short-term is what we call the rescue inhalers, and that's albuterol or Proventil. And then Serevent or Foradil are our long-acting maintenance. So that's for somebody that knows that they don't just need a rescue inhaler, they need something every so many hours. So a beta-2 agonist is going to encourage the beta-2 receptors to dilate, to bronchodilate. They can be short or long-term medications. The short-term, I've already said this, is the rescue inhalers. So the most common side effects or adverse effects that you're going to see with that is xerostomia. So that's the one that we always, for so many drugs, I mean, you guys are going to get so tired of hearing that, but it's so many drugs cause xerostomia. Increased heart rate, nervousness, tremors can also be seen, but those are more with the short-acting rescue inhaler. And I think that's all I had on that slide. And then for the corticosteroids, these are also used as more of a controller or a maintenance. And they're used to control the symptoms, and they work by blocking the inflammatory receptors, and the potency can be increased with the severity of the condition. So if somebody is very mild, they might only use a small amount. They're always very, very cautious with corticosteroids because there's a lot of adverse effects. Long-term corticosteroid use is not ideal. They're wonderful anti-inflammatory medications, but there are so many things to consider. So potency is going to vary definitely on patient's need. It's not just like kind of a one dose for everybody. The adverse effects of inhaled corticosteroids can be minimized by a spacer. And I just wanted to make sure my cursor's in the right place so you guys can see. This is a little image, but if you look up spacer, you can see all different images of it, but it basically chambers the medication. So they chamber in the dose and then they open it up and take a big inhale. So it gives this kind of opportunity for you to prep and get the medication down deep into the lungs, and not so much the medication will be in the mouth, because this is an important one for you guys to know. Oral thrush or candidiasis is a big adverse effect of the corticosteroids. And we don't, that's something that patients don't want to have to mess with at all. Pharyngitis is also a side effect, but the fungal disease or the thrush is the one that we really want to try and avoid. So if you ever have a patient that's suffering from that, that's using an inhaler, a corticosteroid inhaler, and keeps recurring having these oral thrush or Candida albicans, then you can recommend a spacer to them. So some other for the systemic tablets, you can see there's a lot of side effects that are undesirable. There's insomnia, nervousness, increased appetite, impaired glucose. So that's important for patients who, if they happen to have COPD and diabetes, type 2 diabetes, that would just be awful. So you got to think about that. And then there's also the long-term use of a corticosteroid. They call it moon face. It's like a swelling, basically. So the face looks very round. And then the buffalo hump is like a fatty deposit on the back of the neck, thinning of the skin, impaired glucose, sodium and water retention. So there's swelling and edema, hypertension, osteoporosis, and fractures. It's nothing that you want to have to be on high dose for a long time. Some people do because of chronic conditions, but it's not ideal. So these are all the long-acting inhaled corticosteroids, and are either just a steroid only, like Flovent or Pulmicort, or it's a combination beta blocker and corticosteroid, like Advair. We've heard that a lot, Advair, or Formoterol, Symbicort. Symbicort is one I've seen that on people's medical histories pretty often as well. So those are combinations. So they work to reduce inflammation and open up the airways. How am I doing on time? Oh, pretty good. Okay. So leukotriene causes the airway to narrow. So a leukotriene receptor antagonist will help to block that. So adverse effects from that, though, would be headache. And you'll see Singulair quite often. I've seen Singulair as a pretty common asthma medication, and that's a pill. Then we have the anticholinergics, the inhalers, and these inhalers block cholinergic receptors in smooth muscle, resulting in bronchodilation. And then you'll remember that oh my word, parasympathetic nervous system of the bronchioles, they constrict when you're in rest and digest, or they're just not as dilated when and you just don't need as much oxygen. So the adverse effects include the low anticholinergic, which is good. This is a good thing. So the adverse effects of these drugs are that there is not as many of those anticholinergic effects like the drying eyes, the constipation, decreased urination. So that's what it means by low anticholinergic effects. There is some nausea and that metallic taste in the mouth. Sometimes they just call it an altered taste, but it can be a metallic taste. And then we have short-term and long-term Atrovent or Spiriva or Spiriva. Okay. So here's another chart for you guys to just kind of get familiar with the medications. You can fill that out, and that way the how and the adverse effect, just realize that how is also mechanism of action. So just knowing that those are likely going to be questions on exams is the how and the adverse, and that's why this is here, is to help get you familiar with these medications, the mechanism of action, and the adverse effects. Okay, so a couple more case studies. I think there's one after this too. So a patient with moderate persistent asthma and allergic rhinitis, their current medication is they take a Centrum multivitamin, they take Claritin daily, they take Advair twice daily, and then they take Proventil or albuterol once in a while. Symptoms that they're having, they're getting a white buildup lining on the upper palate and the tongue and the back of the throat that can kind of be scraped off with gauze. So what would the white buildup in the patient's mouth be?
Thrush.
Mm-hmm. Yeah, fungal infection, candidiasis, or thrush. Yep. And which one of those medications is causing it?
Albuterol.
Try again. Close.
Proventil.
It's Advair, but it's the other one. Now I'm second guessing myself. Hold on. Let's go back. Let's back up. Because it's the corticosteroid that causes the thrush. So that was Advair. And the albuterol is just an agonist, beta blocker. I mean, beta agonist. So I was wondering for a second if it was a combo, and that's why I was second guessing myself. But so albuterol by itself is just a beta 2 agonist, and so that's not going to cause thrush. But the corticosteroid is the one that we have to watch out for. So now the combination ones so Advair is a combination one. So Symbicort and Advair, Flovent and Pulmicort. Those are the ones that could cause thrush. Okay, and last question, how can you counsel the patient to prevent or minimize the thrush from recurring? Yeah, somebody wrote it. Yeah, so you can ask them or you can tell them about a spacer if they've never heard of that before. You could recommend that. If it's a recurrent problem, if they keep having to take like a oral, antifungal type medication on top of it, you could talk to them about mentioning it to their doctor, saying, I keep getting reoccurrent fungal infections. Possibly it would be able to change medications, but that's obviously not necessarily something that we decide at all. But probably recommending that they cleanse their mouth immediately after the medication, keep their mouth really clean, and then recommend a spacer. Those would help. And then someone wrote, I thought you couldn't wipe off thrush. Sometimes I know that when you wipe it off, it can be very red and irritated underneath, but it should be able to come off, but it's usually red and irritated underneath. Okay, so last slide. So a patient with asthma started running 3 to 4 times a week. Symptoms soon, shortness of breath, likely out of shape. I'm not sure why that's a question. Current medication, so they take Advair twice daily. They take albuterol as needed. So that's their rescue. And then they take Advair twice daily. And then they take Synthroid they obviously have a thyroid. And then Advair took more, but there was no relief. So they took their Advair more than twice a day. What's causing their symptoms? I don't know if I like these questions. I think I have to edit. Yeah, they could have something going on, like maybe they have allergic rhinitis, or maybe, who knows, maybe they got a cold or something like that. So there could be something like that triggering some of those symptoms. Exercise-induced asthma is kind of where I was going with that. The fact that the Advair isn't really helping, I don't know. I don't really like this question, to be honest. Despite receiving a higher dose of Advair, why is it not effectively controlling the shortness of breath during exercising? It could be, despite receiving a higher dose of Advair, why is it not? Okay, what do you guys think? Expired? Oh, maybe. Oh, it says it's expired. Oh my gosh, you're good. Who's that? I think a couple of you said it. Vanessa put it there. Yes, maybe that's why. So it could be that their rescue inhaler. So this is their anti-inflammatory that they're taking, but their dilator, the one that they use to like really get in there and dilate is maybe not working as effectively. So that's a good option. I still feel like it's a little bit weird because the Advair is a combo, right? So it should have done something. So I don't know. I'm not a huge fan of this question block, but anyways. Okay, so that wraps up respiratory. And I think we're done with a few minutes to spare. So do you guys, 6 minutes to spare. Does anybody have any questions over what, anything from last week or anything from what we just covered? No questions coming in. I think I have some office hours. You guys always remember you can go into that that Google Doc where I have some office hours posted. I think I have some this week in there. I have to go and check and see exactly what day it is. But it's usually during a lunch. And I know it's hard if it's during a lunch because if you guys are in clinic, you want to go eat. So I totally get it. But I just was going to check it really, really fast here. I have it right here just to give you guys a reminder. The next one is on the 19th, which is Friday. So I have lab in with the seniors, and I have lunch from 12 to 1. So it says 12:15 to 1:15, but I'll probably do my office hours from 12:15 to 1 because I have to get back into lab. So it'll do 45 minutes on Friday. So if anybody has any questions that come up during the week and they want to pop in, and I'll be on this Zoom link for 45 minutes on Friday too. Okay, you guys have a great afternoon, and I'll see you later.
Leslie, I have a question.
Yeah.
Sorry, I'm chewing. Hold on. So it's kind of related